Hello and welcome to Community Paramedicine, the introduction. We will discuss how our program will unfold as you move forward. Community Paramedicine, Mobile Integrated Health. The program will be broken down into the following sections: the introduction, history, beneficiaries of a successful Mobile Integrated Health Community Paramedicine program, scope and availability, requirements to create a Mobile Integrated Health Community Paramedicine program in Rhode Island, eligibility, referrals, and administering care, and we'll culminate with a question and answer period, where we ask the question, you provide the answer, and we tell you if you're accurate. So I hope you enjoy the program. Let's get started. Before we can start discussing the specifics of Mobile Integrated Health or Community Paramedicine, we should probably come up with a definition of Community Paramedicine. The U.S. Department of Health and Human Services defines Community Paramedicine in the following manner. Community Paramedicine is an organized system of services based on local need, provided by emergency medical technicians and paramedics, which is integrated into the local healthcare system and overseen by emergency and primary care physicians. Now, in Rhode Island, community paramedicine and mobile integrated health programs will be staffed with emergency medical technician cardiacs and paramedics. We'll talk more about that later in the production. Specific regulation and guidance for the creation and implementation of a mobile integrated health community paramedicine program can be found in Rhode Island statewide Emergency Medical Services Protocols 2022.01. The specific protocol is 1.05, Mobile Integrated Health Community Paramedicine. However, providers should realize that there may be more applicable protocols which will guide them during their creation of the Mobile Integrated Health Community Paramedicine program and the implementation thereof. Initially in this presentation, we used a pretty big paintbrush to create a definition for community paramedicine. That was actually a national definition, and we now want to look into the way the state is describing and defining mobile integrated health and community paramedicine. The following is an excerpt from the Rhode Island statewide EMS protocols 2022.01. Description of mobile integrated healthcare community paramedicine. Mobile integrated healthcare is the provision of healthcare using patient-centered mobile resources in the out-of-hospital environment. Mobile integrated healthcare concept is envisioned to be an organized system of services based on local need. The services must be provided by advanced EMT, cardiac, and paramedic licensed practitioners who are integrated into the local healthcare system, working in a collaborative manner with physicians, mid-level practitioners, home care agencies, and other community health team colleagues. Oversight of all activities must be provided by emergency and primary care physicians. The purpose of the initiative is to address the unmet needs of individuals who are experiencing intermittent healthcare issues. It is not intended to address long-term medical or nursing case management and is not a replacement for traditional home health services. We've taken a minute to underline some of the key components to mobile integrated healthcare, community paramedicine. As you look, you'll see these words come up again in this presentation. Patient-centered, mobile resources, care in the out-of-hospital environment, an organized system of services, local need, integrated into the local healthcare system, working in a collaborative manner to address the needs of individuals. These are components of a team approach program. This system is designed to have a multidisciplinary approach, as you'll see further on in this presentation. Some may ask, what makes EMS a logical entity to implement a mobile integrated health community paramedicine program? Well, I suppose we could start by simply stipulating to the fact that it has the word paramedicine in the title, but it goes a little deeper than that. This is another excerpt from Protocol 1.05, Mobile Integrated Health Community Paramedicine. Emergency medical service practitioners have traditionally functioned as a mobile healthcare unit and are a logical resource for providing healthcare to the community as an extension of the primary care network, provided a formal process is followed as outlined in this protocol. This protocol enables an EMS service to form a coalition of partners for the purpose of providing community-based healthcare services within the scope of practice of the EMS practitioner. A community that is experiencing a gap in healthcare services, as evidenced by a community needs assessment, may elect to utilize the capabilities of the EMS system in collaboration with primary care providers and/or a hospital. Only EMS practitioners who have met the requirements of this protocol may practice under these guidelines. And the Rhode Island Center for Emergency Medical Services of the Rhode Island Department of Health is available to provide consultation and support to mobile integrated healthcare initiatives. There are educational pathways which will assist you in achieving an IBSC board certification as a certified community paramedic. You can find several programs of study if you look online, which will prepare you for the board certification process in community paramedicine. One is through the NAEMT, and if you look on their site, they explain that courses within the series may be taught individually or combined and include the following: motivational interviewing, wellness and nutrition, hospice and palliative care, mental health and substance abuse, geriatrics, pediatrics or children with special healthcare needs, endocrine disorders, respiratory disorders, cardiovascular disorders, pharmacology, neurological disorders, the clinical medicine of community paramedicine, introduction to community paramedicine and mobile integrated health, and clinical rotations. Another program of study is through Columbia Southern University, and they list their course learning objectives as follows: define determinants of health, recognize the role of community paramedics in addressing community-based needs, describe health promotion strategies, identify components commonly found in a patient's plan of care, discuss the importance for interprofessional disciplinary collaboration for proper patient care, relate ethical and legal considerations of mobile integrated care, recognize the factors that affect the monitoring and management of the chronic disease patient, apply knowledge of the principles of mobile integrated care. Properly educating staff to rise to the challenges of mobile integrated health and community paramedicine may not be inexpensive, and it certainly won't be easy. However, to create successful mobile integrated health community paramedicine programs, community paramedicine practitioners need to be well equipped to interact with other healthcare providers as they collaborate and make decisions with the patient and their practitioners in their best interest, in hopes of allowing them to lead healthy and fulfilling lives in the comfort of their home and within the community. Your service may want to implement a selection process so you're engaging the most skilled and ambitious providers in your service to be front-facing with the public. Community paramedics are the ambassadors of EMS moving forward and will be spending considerably more time with patients in their residence than the crews that would go assist them when they are experiencing an acute emergency. Your service has any questions on implementing a community paramedicine mobile integrated healthcare service in your department, feel free to reach out to the Rhode Island Department of Health Center for Emergency Medical Services office. They will be glad to assist you. Once you have a list of patients that your service will be visiting, you will need to determine a schedule so that your mobile integrated health community paramedicine practitioner is available during that time and is committed primarily to that role. It would be counterproductive to have that provider leaving in the middle of visits to respond to other calls. So that provider really needs to be dedicated to that program. The amount of patients your service will be able to visit is going to be dependent upon the amount of providers or practitioners that you have assigned to the community paramedicine mobile integrated healthcare unit. Certain departments have chosen to partner with neighboring departments to achieve this objective, creating essentially a regional community paramedicine mobile integrated healthcare program where departments in a specific area will share aides. So maybe one department will have an assigned day for somebody in their area. So those are matters that can be worked out within the leadership of your department and amongst the leadership of your neighboring departments. We wish you well in your endeavor to create a community paramedicine mobile integrated health program in your service. As always, we hope that you remain physically safe and emotionally well. Welcome to Community Paramedicine, where we look at the history of community paramedicine. I just wanted to give you a glimpse into a brief history and a vision of how the future looks for Rhode Island Emergency Medical Services as far as it pertains to mobile integrated healthcare and community paramedicine. There are other services across the country, from King County to Florida, that are utilizing this program to better the lives of the people that they serve. The following can be found on the Rhode Island Department of Health website. It's the Mobile Integrated Health and Community Paramedicine Program mission statement. In researching this topic of mobile integrated healthcare and community paramedicine, I ran across an article in the Annals of Emergency Medicine, volume 67, number 3, March of 2016, pages 361 to 368. Written by Brian Choi, who's a physician for Lifespan, Kenneth Williams, who's a physician for Lifespan, and a tireless advocate of emergency medical services, signs our protocols. So if you don't know who Dr. Ken Williams is, that'll be another PowerPoint presentation for you. And Charles Bloomberg got together and wrote this article entitled Mobile Integrated Healthcare and Community Paramedicine, an Emerging Emergency Medical Services Concept. If you get time to read this article, it is a very good read from start to finish. There is a lot of valuable information within this that supports mobile integrated healthcare and community paramedicine, and it's clear that this program will work in this state. It will work with the buy-in from the key players. So thank you to Dr. Choi, Charles Bloomberg, and of course, Dr. Kenneth Williams for taking the time to write that, publish that in the Annals of Emergency Medicine. If you take all of the ingredients that would make a successful mobile integrated health program, community paramedicine program, and you put them into buckets, as you achieve these objectives within your planning for the program to take off, you'll notice that any shortcomings in any of these buckets will affect the efficacy of your program. The first bucket, you need to find out the community needs and the perceived value of the program you're going to put into place to assist these people with their needs or the community's needs. The community's needs presentation may change from region to region, or even in a small state like Rhode Island, from county to county. You need to make your program sustainable. There are grants that services can apply for. However, moving forward, you need to make sure that your program is funded and you have achieved the appropriate reimbursement for this service to keep it going, to get this off the ground. You need to make sure that you're getting that money back into your service. 3, technological upgrades, medical devices. You're going to see as we move forward that in the 1970s, into the 1980s, they weren't all that worried about whether or not they had the greatest technology. They were more worried about having staff, trained, educated people staffing the ambulance and a quick ride to the hospital. And as we've progressed in history, we've now embraced things like 12 lead EKG monitoring with telemetry, waveform capnography to include quantitative and qualitative monitoring devices, the glucometer, which wasn't on every ambulance in years past, even the AED, that wasn't always mandated on every BLS ambulance. So as we move forward, there's technological advances that allow us to do the things we need to do. Computers, electronic patient care reports, they allow us to capture data. Later on, you'll see that that's important. Buy-in and with me, very important. You need buy-in from all of the key players, including the patient, to have a successful mobile integrated health community paramedicine program. The hospital wants to take part because we are potentially reducing their workload and the influx of people that maybe are being transported to the emergency department that may be able to benefit from a less acute care environment. After the mobile integrated health practitioner evaluates them in their residence, and that direct consult with their primary care physician during that visit may alleviate some of the impact from these patients repeatedly going to the hospital. Or EMS services may notice a slight decrease in call volume, especially to the same address for a patient who may call frequently to go to the emergency department for what is in many cases a clear non-urgent or non-emergent complaint. Physicians such as the primary care physicians want this buy-in because it enables them to create care plans for their patients from which that patient will benefit. They'll be able to live a longer, healthier life. The next bucket is education, training, and protocols. So there are certification processes to get paramedicine certification level that's recognized, tools that have Pepsi-approved programs where EMT cardiacs and paramedics can attend these courses and seek the appropriate education and training so they can be effective practitioners in the mobile integrated health community paramedicine arena. Of course, the protocols need to be written so people know what's expected of them, such as EMT cardiacs and paramedics know what's expected of them when they are taking care of these patients. And Rhode Island has done a great job with the statewide EMS protocol, section 1.05, where it has really broken down all of the expectations of the services, the medical director, the primary care physicians, and even the patients, so we all know what book we're reading off of. People truly do best when they know what's expected of them. And last and certainly not least is a QA/QI plan. You need oversight to make sure that the program is working, that the practitioners are performing up to a level that's excellent and standard of care is being afforded to these patients. Data collection is very important because you want to be able to prove value of your program, and that will help perhaps fund that program moving forward. Of course, if you have a successful, people are more likely to fund a successful program than if you cannot prove that it's successful at all. So that goes into data collection and analytics, report writing, documentation, document sharing, such as current care is a great help to these services. As we look along the historical pathway of EMS, we'll see that we're better equipped now than we have been in decades past, simply because of the technological advances, because EPCRs, our ability to capture data and analyze data, people embracing education and training protocols, and the buy-in from all of these different key players within the Mobile Integrated Health Community Paramedicine program. The first mobile integrated health community paramedicine programs in the United States were designed to address the needs of those who resided in rural communities. Communities began exploring alternative solutions for low acuity patients or patients with chronic medical conditions who resided in rural communities and did not have home health nursing or other home health services available to them. At that time, hospital emergency departments and EMS services were becoming overwhelmed and were becoming inundated with very low acuity and repeat patients. Of course, we spoke about funding a little bit earlier, and although reimbursement was designed for emergency ambulance transport, studies placed the number of low acuity EMS transports at about 10 to 40%. These facts beg the question, why do people use EMS for non-emergent transportation to the hospital? They came up with the lack of access to or availability of primary care. So right now, if a person has a good relationship with their primary care physician and they have a problem, they can go on a secure site and either send their primary care physician a communication, or they can make an appointment to go in and see them, and the matter will get resolved. People without primary care providers often use the emergency departments as their primary care provider. So they realize that the situations that they're in sometimes are not really emergent or urgent. It's just that they're pressed for time. Lack of insurance and lack of transportation, especially in the rural communities in certain parts of the country. In Rhode Island, you could be from Westerly to Woonsocket in about 60 minutes if you're driving the speed limit on a day where there's not that much traffic on the 610, 95-37 split. Certain parts of the country, it may take you 2 hours to get to the nearest emergency department. In 2002, the CMS created a new ambulance fee schedule, setting new reimbursement levels for specialty care transport. This defined the scope of practice of the paramedic as critical care providers in certain instances and allowed services to bill for that service. And remember earlier, we need to make sure that if we are offering a service, that it is sustainable. You may be able to get some startup money initially, but for that service to continue on, you need to make sure that you're paying your bills. So this, to some, opened the door for us to bill for non-traditional services. In 2006, 24.1% of all emergency department visits were semi-urgent or non-urgent. Studies placed the number of low acuity EMS transports at that 10 to 40% mark. So we need to realize who our customer is. The data we have collected and the data we have analyzed is pointing us in a direction that we can't be resistant. We can't look the other way and say, well, we understand that almost 40% are non-emergent, but we're going to keep on bulldozing through this and hope that we get reimbursed for emergent transfers. Enter Mobile Integrated Health Community Paramedicine, where there are a lot of winners in these programs. Prior to the 1980s, EMS was just getting started, and they were trying to perfect ways of getting patients to the hospital and filling the ambulances with educated and trained staff. At that point in the history of EMS, there wasn't much room to expand out and create specialty areas within paramedicine. Since the 1980s, EMS medical directors, system administrators, and paramedics have acted to expand the scope of service EMS provides, and in some cases, the scope of practice as well. During the 1980s, they were still utilizing equipment that we would perceive today as being antiquated. The physio control at the time, LifePak 5, was in service, which didn't really have 12-lead EKG transmission capabilities. You could move some of the leads around if you were savvy enough to do so, but there wasn't a true 12-lead EKG that would turn off the filters like today. Also, they were still using the paddles in the back of the ambulance. So we haven't at this point progressed to where we need to be to make mobile integrated health and community paramedicine a successful program. The 1990s brought some slow progress. In most cases, the physio control at the time, LifePak 10, was the upgrade from the LifePak 5, 3 batteries, and the monitor did not separate into 2 pieces. The AccuCheck made its presence known. You would have to take and put a large sample of blood on the strip, and it would count down for quite a bit of time before it gave you a blood glucose reading. Also at that time, in this region, we were still using paper for PCRs, which, as you can imagine, makes data collection, especially for analytical purposes, very difficult. So that component that still wasn't where it needed to be at that point in this region or in this state to really move forward and create a successful mobile integrated health community paramedicine program. In the late 1990s, Orange County, North Carolina, and the state of Idaho independently incorporated alternative approaches to the low acuity patient. Initiated in 1996 and 1997, respectively, these programs continue today. The Orange County program enables paramedics with additional training to choose alternate disposition for patients based on their assessment of the patient's need. Low acuity patients can be treated and referred to a primary care provider for follow-up. Alternatively, the patient can be transported by ambulance or other appropriate means, for example, from personal vehicle, wheelchair vans, or taxis, to a physician's office or some form of primary care clinic. The model that Rhode Island currently uses does not give paramedics that leeway. Right now, the treat and don't transport, or the treat and transport to a facility that is not a hospital emergency department, is only in effect if the patient is enrolled in a mobile integrated health community paramedicine program and there is direct communication between the patient's primary care provider and the EMS personnel on scene. Today, EMS services have laptops where they are generating ePCRs, making data collection and analyzation much easier for the state. There is the LifePak 15 and Zolex series, which acquire and can transmit the 12-lead EKGs, quantitative and qualitative measuring devices. Some progressive departments utilizing the iStat or the ultrasound that's portable. So we are in a state where we can truly make mobile integrated health community paramedicine a successful program. Thank you for viewing this presentation. Hello and welcome back to Community Paramedicine, Part 1, Section B. Let's look at who benefits most from a successful mobile integrated health community paramedicine program. The result of any healthcare program or initiative should be patient as the primary beneficiary. Some patients have the inability to keep primary care appointments, or maybe they make poor health choices, or non-compliant with their prescription medication regimen. Perhaps they have dietary concerns. There's a misunderstanding of their prescription medication regimen and their diagnoses. They may have fear and uncertainty, and there may be safety concerns within their residence. And all of these components may lead to an exacerbation of the symptoms of their primary diagnosis. And when that happens, they access the 911 system, they access the healthcare system by calling 911. EMS is dispatched to their residence. EMS makes an assessment, provides treatment if necessary, and transports that person to the emergency department, where they are assessed and treated as appropriate. Then they are discharged, usually back home, and they're discharged with instructions to follow up with their primary care provider. Now, you can see this puts them right back at the top of this cycle. And what we are trying to establish is a communication between the patient, EMS, and the primary care provider so as to reduce noncompliance or to reduce fear or uncertainty, to make a reduction of safety concerns within the patient's residence so they don't fall or they're not put in harm's way where they have to access the 911 system again and be transported to the emergency department. We want to create an understanding and educate the patient as to dietary needs or health choices or compliance with a prescription medication regimen, and even understand their diagnoses. That is all with the hopes that that will reduce the amount of times they need to access the healthcare system via 911 and instead can make contact with their primary care provider through the mobile integrated healthcare community paramedicine system, and that will keep them out of harm's way, help them live a more productive and healthy life. So, what other stakeholders are there in this dilemma where we have overcrowding of the emergency departments and inundation of the healthcare services and systems within a community because of readmissions? The Rhode Island Department of Health website has posted that readmissions in Rhode Island cost over $10 million a year. So you may say, why? Why does that cost so much? Well, hospitals lose revenue due to readmissions within a specific amount of time for the same diagnosis. Certain insurance carriers, Medicare, Medicaid, may not reimburse them for those patients who return several times a week, month, and in some cases a day for the same medical condition. EMS services are inundated with increase in their call volumes. And when they respond to these calls, they're going to respond to the call with lights and siren. And that also puts the providers and the public at some degree of a risk that goes along with responding to a call. And if we can head that off and make the patient a priority, help educate the patients, we may be able to reduce some readmits, some people that call frequently that don't necessarily need an ambulance or don't necessarily need to be transported to an emergency department, but maybe can wait until contact can be made with their primary care provider during normal business hours. Now, this is not to say that people should be dissuaded from calling 911. There are certainly medical conditions and traumatic injuries that require immediate attention, and those people should absolutely be calling 911, accessing the healthcare system, getting an ambulance started to their location, whether it's their residence or workplace or the roadway, so they can immediately be transported to an emergency department for evaluation and treatment. Although community paramedicine has been around for a couple decades and in full force in certain parts of the country, this is an exciting time to be part of EMS in the state of Rhode Island, where we now have two models of EMS. We have the traditional model where somebody has access to the 911 system. It goes through the 911 dispatch system where Those dispatchers are now trained and educated to ask questions and provide instructions to patients or their families. An ambulance is dispatched to the location where the patient is, whether it's their residence or workplace or the roadway. Uh, EMTs, cardiacs, and paramedics are assessing the patients, treating them, providing treatment if necessary, en route to the closest, most appropriate receiving facility where they are again assessed and treated, and they undergo testing and imagery, and the trajectory of their future healthcare is dependent on why they went to the emergency department in the first place. Some people are admitted, some people are discharged to long-term care facilities or skilled nursing facilities, and some are discharged back home. Throughout this period of time, there are people who are analyzing this data, and that's such an important role. When you have the data, you can analyze it, you can find shortcomings in your model. So the traditional model is a call to EMS, call 911, the patient's transported to the hospital. And now we realize that we have this group of people who would benefit from mobile integrated health or community paramedicine, where there's a collaboration between uh, the network of primary care providers, including their physicians or PAs or NPs or RNPs, and there's this group that has gotten together and are able to create a memorandum of understanding to work with EMS, uh, with trained and educated mobile integrated health community paramedicine providers, where we can go to these people at their residence and work with them. And maybe we can educate them or root out some safety concerns within the residents, or maybe make them feel less afraid or less anxious about their medical condition. The more we can educate them about their medical condition, the less anxious and fearful they will be, and the more they take part in their prescription medication regimen, dietary, and other health endeavors, the less likely it is that they will need to access the healthcare system through 911 with transport to the emergency department because of exacerbations of a medical problem that could have been avoided. So the patient actually benefits because they are able to stay within their residence and perform at their baseline level of functioning. Others in other parts of the island. One of the components of mobile integrated health or community paramedicine is educating the patient about their prescription medications and how to read the instructions. A lot of the viewers of this uh, program right now are ALS providers, and many of you have been to residences where somebody may have a low blood pressure, and you're trying to root out why their blood pressure is so low right now, and everything else kind of seems okay. And then you ask them about their metropolol that they take, and they say, "Well, I'm supposed to take 4 pills a day," and it comes out 4 pills is 100 milligrams a day, and they're only supposed to take 50. They're supposed to take 1 pill twice a day. So now you have a patient taking twice the dose of a beta blocker, and of course they're going to experience an acute medical emergency, and hopefully that can be met and rooted out quickly before the patient falls and maybe suffers some traumatic injury that takes them out of their home to the point where they can't stay at home because their level of function has deteriorated because they hit their head, or they had a head bleed, or they have a fractured pelvis, or a fractured neck or back, ribs. So something as simple as educating the patient as to the time of day they have to take their medication and the exact amount uh, is important, and that can keep people from long-term disability. The same is true with dietary restrictions. So you may have a program where you're a little bit more focused on home safety assessments. How many houses have you walked in where you look at the smoke detector, or where the smoke detector is supposed to be, and it's not even in the ceiling, and it's sitting on the table, and the little flap is open, and the battery is out, and this person who may get to the store twice, 3 times a month, or may not have the money to replace that battery, looks at you, and in this, you can see to them that that may not be a priority. They don't see it that way, And maybe if you could get a battery in their smoke detector, that could save their life, and that could save uh, an entire apartment complex. That mats on the floor and railings within the bathroom that assist them from uh, falling while they're attempting to move their bowels or urinate or shower even. So these grip, slip, trip, fall hazards are important. And then again, there's another component to the mobile integrated health and community paramedicine where these people may have to go and be evaluated. They may have to go to a lab to get imagery done or certain blood tests done, although community paramedicine and mobile integrated health have resources where some labs can be taken in the residence. There are times that the person has to be sent to another place, like a lab or a clinic, where they're not being transported to an emergency department. They're going to a specific clinic or they're going to a specific place and to return home without having an 8, 9, 10 hour stay in an emergency department just to get labs. So, how you see your mobile integrated health and community paramedicine program in your service may vary from another service close by. Welcome to this section of Community Paramedicine, where we look into the requirements to create a mobile integrated health community paramedicine program, as illustrated in Rhode Island EMS. Requirements to create a mobile integrated health community paramedicine program can be found in Rhode Island statewide EMS Protocols version 2022.01. Specifically, Protocol 1.05, Mobile Integrated Health Community Paramedicine. Requirements to create a MIH Community Paramedicine program in Rhode Island. 1. General project description. List the community or communities to be served and name the program. Define the service-based location or locations. Define the unmet community health needs that need to be addressed. Describe the community health teams which the service will partner. And the methodology for addressing the healthcare needs, and include the enhancement of the EMS response system which will result. Service agencies may find it fiscally or logistically beneficial to partner together to create a service for a mobile integrated health community paramedicine within a region. This is why it asks to define communities or define service-based locations. There needs to be a service needs assessment done which will illustrate the unmet community health needs in that region. Health needs may vary from region to region or service to service, despite the fact that Rhode Island is relatively small compared to other states. Different counties within the state may have different needs for their public. So Washington County may have different needs for the patients in that area versus East Bay or Providence County. 2. Community needs assessment. The EMS agency, hospital, primary care providers, and any other partners must provide a needs assessment that demonstrates the gap in healthcare coverage mobile integrated health community paramedicine intends to fill. 3. Medical direction. All licensed services must have a medical director, and the requirements as it pertains to mobile integrated health community paramedicine states that there must be medical direction involved in the MIH CP services, which will be coordinated with the current medical director, if not the same, who is in charge of creating medical policy, CQI, and operational concerns such as best practices. 4. Patient interaction plan. Describe the nature of anticipated patient EMS practitioner interactions. Describe how the patient community will be educated to have realistic expectations of the EMS practitioner in these interactions, and define who will be providing the MI8 services and how the services would fit in with the regular EMS staffing of the service. Providing education to the patient community as to what realistic expectations that they should have of the EMS service, the EMS practitioner, and the healthcare system as it pertains to mobile integrated health community paramedicine is paramount to the success of your services program. The mobile integrated health community paramedicine presentation you are listening to is geared towards ALS providers, and most of you here have a substantial amount of experience in the field of EMS. So think back at the last patient you encountered where you went to their residence or you went to a scene and the patient was attempting to determine whether to go to the hospital with you or not. Perhaps the patient or a family member may have spoken up and informed the patient that if they are transported by an ambulance, they're going to be evaluated at the hospital faster, and they're going to be actually treated faster, and they will probably discharge from the ER faster than if they went in a private vehicle. Now, there are some medical conditions and traumatic injuries that clearly need to be transported by EMS to assess, treated en route to the hospital, and treated immediately on arrival at the hospital to yield the most favorable outcome for that patient. However, there are other conditions where it doesn't matter whether the patient goes to the hospital via an ambulance or a private vehicle. Either way, they're going to same care, and maybe they'll be sent to a different section of the emergency department. Maybe they'll be sent to triage. Maybe they'll be sent to the waiting room. So this is a gap in patient education that you may have had experienced in your career, where the patient or the family is not really educated, or they heard something on a social media site where if you call 911, you will be transported to the hospital faster, receive more prompt care, and be discharged quicker than if you take your own private. So setting these realistic expectations will increase the likelihood that the perception of your success as a provider is greater than if their expectations are different than what you are there to provide. 5. Training. Describe what training will be provided to enable the EMS practitioners to deliver the services described above. List the objectives and outcomes of the education and training plan. Document who will be responsible for training, oversight, and coordination, as well as their qualifications. There must be a continuing education and credentialing process in place with each EMS practitioner's participation. Such a process shall be approved by the EMS Services Medical Director. There are educational institutions and online programs where providers may complete community paramedicine preparatory programs to achieve their IBSC community paramedicine certification. Other education programs may be approved by the department's medical director or Rhode Island Department of Health. Six, quality management program and data collection. The EMS service shall conduct a quality management program specifically for the community healthcare program. The QM program will incorporate all the components of an EMS QM program as specified in the Rhode Island Code of Regulations, Emergency Medical Services 216 RICR 2010-2. Describe what data demonstrates the need for this project, if any. Describe the data to be collected to demonstrate the impact of this project on the population served. And describe the data reporting plan and how the RICEMS will receive data and reports. When you're talking about the sustainability and defending the value of a program of any kind, data collection is paramount. You need to have some type of objective findings to determine if there was an issue. In this case, it would be the unmet needs of the community. You need to determine if the program you have in place is now meeting those needs and how effective that is. This will enhance the likelihood that these programs will be funded moving forward. So it's very important to collect the data, that way it can be analyzed, and we can either move these programs forward as is, or we can pivot and make changes to some of these programs to make sure we're achieving our objectives. 7. Documentation. Electronic medical records shall be maintained and shared with mobile integrated health community paramedicine partners. Copies of EMRs shall be maintained by the EMS service and made available to the Rhode Island CEMS. Mobile integrated health community paramedicine practitioners may activate the 911 system for the patient at any time they deem as necessary, and that is illustrated in more depth later on in the protocol. However, activation of the 911 system, whether that be via phone, calling 911, or a portable radio summoning an ambulance, this will generate a PCR for the transporting EMS service as well as the home visit documentation and electronic. The Rhode Island statewide EMS protocols, Protocol 1.05, Mobile Integrated Health Community Paramedicine, was designed and established to assist service providers in creating their own mobile integrated health community paramedicine programs. If you require further assistance, please reach out to the Rhode Island Department of Health, Rhode Island CEMS office. Thank you for viewing this presentation. Hello and welcome to Community Paramedicine. In this segment, we will look into scope and availability of the Mobile Integrated Health Community Paramedicine Program in Rhode Island. Any agency planning on establishing a mobile integrated health community paramedicine program must be a licensed EMS agency within the state of Rhode Island, pursuant to Rhode Island General Law 2341 and Rhode Island Code of Regulation Emergency Medical Services 216 RICR 2010-2. The following are some goals of mobile integrated health community paramedicine programs in Rhode Island. Provide urgent follow-up care when other home health resources are not available. Create multidisciplinary teams to evaluate the needs of patients who frequently access EMS, reducing repeat EMS access and improving the quality and effectiveness of care. Assess the need for chronic disease screening and help to initiate that screening in collaboration with a primary care provider. Screening and education for chronic disease in homebound patients when other options have failed. Provide on-scene treatment without transportation to an emergency department by protocol and with real-time consultation with the patient's primary care provider. Injections of vaccinations and immunizations in the home. Obtaining urgent laboratory specimen collection in the home as ordered by the primary care provider. Public health functions to include direct active monitoring or direct observed therapy programs as ordered by the Rhode Island Department of Health, and home safety assessments including fall prevention and fire safety. There may be instances where the patient's primary care provider will require the patient to have urgent follow-up care and be unable to render other services for that patient to include home health nursing or other home health services, where they may submit a referral for that patient to receive mobile integrated health community paramedicine services. As you view this production, several names or addresses may actually come to mind when you see this slide presentation, and you may see the value in establishment of a multidisciplinary team to evaluate the needs of patients who frequently access EMS, thereby reducing repeat EMS access and improve the quality and effectiveness of their care. There are patients who access the healthcare system via 911 and emergency medical services that don't necessarily require emergent medical treatment and would benefit from having a plan of action set up by their primary care provider, which would keep them out of the emergency department, or perhaps not make them feel compelled to call 911 and summon EMS. For services who have a mobile integrated health community paramedicine program in place, day to day, this may look like an EMS crew responding to somebody's house for the third, fourth, or fifth time that week, and maybe that team has forwarded this concern to the officer in charge of the mobile integrated health community paramedicine program for that department, and that department might reach out to the patient's primary care physician or the patient to determine if they can develop a care plan for that patient and determine if this is a safety concern. Maybe the person has a large amount of rugs on the floor that are slippery, causing them to fall multiple times. Maybe there's a misunderstanding as to the medication regimen, or maybe there's a concern as to their understanding of their underlying medical condition, where if we could tighten that up a little bit and make their home safer, or make their understanding of their medical condition, or educate them as to their medication regimen, perhaps they won't be put in a situation as often where they feel that they need to access the healthcare system via 911. Mobile integrated health community paramedicine practitioners would assess the need for chronic disease screening and help to initiate that screening in collaboration with a primary care provider. The assessment must be within the scope of practice of the mobile integrated health provider or community paramedic as ordered by the PCP. Mobile integrated health community paramedicine practitioners would assess the need for chronic disease screening and help to initiate that screening in collaboration with a primary care provider. The assessment must be within the scope of practice of the mobile integrated health provider or community paramedic as ordered by the PCP. Mobile integrated health practitioners, community paramedics, may provide on-scene treatment without transport to an emergency department per protocol and with real-time consultation with the patient's primary care provider. This should not be confused with a paramedic responding to a patient's house, treating them, and the patient refusing further medical treatment or transportation, or the idea that a paramedic can go to somebody's house, treat them, and obtain a refusal because the treatment they provided was deemed sufficient. This has to be completed under the auspices of the Mobile Integrated Health Community Paramedicine Program in your department, and this needs to be done with real-time consultation with the patient's primary care provider and within the scope of practice of the practitioner on scene and under the protocol set forth by the Rhode Island Department of Health. By this time in this presentation, A theme has probably emerged in front of you. Mobile integrated health and community paramedicine programs must have a full commitment from the patient's primary care provider to work properly. There needs to be a memorandum of understanding executed by both the Mobile Integrated Health Community Paramedicine Service and the primary care provider. This is a team approach. This is a multidisciplinary team venture where you need buy-in from medical direction of the service, medical direction from the primary care provider, patient, and your service, and the Department of Health. This team approach is what will make this program function properly. The primary care provider is not an intervener physician in a negative way where you respond to somebody's house and they want to provide care that goes in one direction and your protocols or maybe your experience have you providing care in another direction. This is a case where this primary care provider knows their patient and their patient's medical history well, and they know trajectory that they want their healthcare plan, and you are the vehicle that's going to assist them in making that happen with the patient remaining home and not going to the emergency department, not having to be transported to the emergency department where they will have to wait long periods of time. And these matters that can be addressed in the patient's residence will assist in unclogging the backup in some of the emergency departments in the state. And of course, the patient remains the center focus, so it will help them continue on with their activities of daily life or activities of daily living so that they can maintain a higher level of functioning and a higher quality of life in general. It is important for mobile integrated health community paramedicine practitioners to understand that assessments must be done within the scope of practice of the mobile integrated health community paramedicine practitioner as ordered by the primary care provider. So the primary care provider should not order any assessment that is not within the scope of practice of the mobile integrated health community paramedicine practitioner, and the mobile integrated health community paramedicine practitioner should realize when that threshold has been reached, if it does at all. So they should know their scope of practice and know the limits of their licensure. Mobile integrated health community paramedicine practitioners may be asked to provide patients at home with injections of vaccinations or immunizations. This is of great benefit to the patient, as these patients who may be more susceptible to getting certain diseases are not forced to leave their home and surround themselves with large groups of people, which may actually increase the likelihood that they would actually get sick. So they can stay in their home, and a mobile integrated health community paramedic may be able to administer these vaccinations or these immunizations right in their residence so they don't have to leave. Mobile integrated health community paramedicine practitioners may be asked to obtain urgent laboratory specimens in the home as ordered by the primary care physician. Now, EMS in Rhode Island has come a long way over the last couple of decades to include everything from glucometers on the ambulances to EKG and 12-lead EKG capability. There are devices such as the iStat now that have made their way into EMS services in Rhode Island, and services may apply for funding through grants to obtain these devices, make collection of specific laboratory results available to them within the patient's residence. And they may be actually asked to collect blood specimens to be sent out to the laboratories. This is as opposed to the patient requiring transport to an emergency department where certain labs are obtained, and the emergency department practitioner contacts the patient's primary care provider and develops their care plan. The mobile integrated healthcare community paramedicine practitioner may be tasked with public health functions such as direct active monitoring or direct observed therapy programs as ordered by the Rhode Island Department of Health. One of the most important functions of the mobile integrated health community paramedicine practitioner will be the home safety assessment, including fall prevention and fire safety. We've all been in people's houses where perhaps the house wasn't as safe as it could be. There may be a disconnect in education between which smoke detectors and carbon monoxide detectors the patient should have in their residence and whether or not they should be hardwired. We've all been in a house where we looked up at the ceiling where the smoke detector used to be and saw an empty spot, only to look on the table and see the smoke detector that was in that spot sitting on the table with an open battery container and no battery within the device. We want to make people's houses safe for them to live in and keep them from harm day to day with items such as grab handles in the bathroom or anti-slip measures where we are not having rug mats on slippery surfaces, which could prevent falls during the day. The slip, trip, and fall hazard is ever important and ever present in most of the patients' homes that we visit on these daily 911 calls. In addition, we have carbon monoxide detectors and smoke detectors, which really need to be assessed so that they are properly functioning, whether they're hardwired or plugged into the wall or they have appropriate battery life, so they're working in the event of an emergency. Mobile integrated health and community paramedicine practitioners empower patients through education and support, maintain a high level of functioning where they may reside in their homes and continue to live a safe. Hello and welcome to Community Paramedicine. This is the question and the answer check-in where we ask the question and you give us the answer and then we tell you if you're correct or not. It's the same thing as a game show on TV, except you don't win any money. True or false? There is no formal process for a service to create a mobile integrated health community paramedicine program in Rhode Island. If you answered false, you are correct. There is a formal process for services to create a mobile integrated health community paramedicine program in Rhode Island, and most of it is enumerated in Protocol 1.05, Mobile Integrated Healthcare Community Paramedicine. True or false? Mobile integrated health community paramedicine programs require a full commitment between the mobile integrated health community paramedicine service and the patient's primary care provider. If you answered true, you are correct. As enumerated in Protocol 1.05, Mobile Integrated Health Community Paramedicine, the MIH-CP programs require full commitments and a memorandum of understanding between MIH-CP services and the patient's primary care provider. True or false? Once a patient is part of the MIH-CP program, they are only treated at home, and the MIH-CP EMS provider should never activate the 911 system for them. If you answered false, you are correct. Mobile integrated health community paramedicine practitioners are advanced life support practitioners and bring with them the knowledge, expertise, and the experience to determine if a patient is experiencing an acute medical emergency which requires immediate intervention, assessment, treatment, and transport to a hospital emergency department. MIH-CP practitioners should make every effort to contact the patient's primary care provider prior to the patient being transported or during transport if they can't be reached and the treatment and transport is time sensitive. True or false? According to the Mobile Integrated Health Community Paramedicine Protocol, paramedics may simply treat patients on any call and leave them at home, even if they are not part of the Mobile Integrated Health Community Paramedicine Program. If you answered false, you are correct. According to the Mobile Integrated Health Community Paramedicine Protocol, paramedics may treat patients and leave them at their residence, but only under direct supervision and contact with the patient's primary care provider, and so long as that treatment is within the practitioner's scope of practice in Rhode Island statewide EMS protocols. This is different than starting treatment on a patient and the patient refuses. Patients in these cases are overseen by their primary care physicians, and the care being provided is within direct communication with those primary care providers. So long as the patient is within the Mobile Integrated Health Community Paramedicine Program and the paramedic is on a home visit, they can treat the patient and leave them behind, but only if they have made contact and are in direct communication with the patient's primary care physician. True or false? Currently, patients who receive home health care and home nursing services are also eligible for mobile integrated health community paramedicine services. If you answered false, you are correct. Patients who already receive home health care or home nursing services are not currently eligible for mobile integrated health community paramedicine services. True or false? Patients must be enrolled in Rhode Island Health Information Exchange or Current Care to be eligible for mobile integrated health community paramedicine services. If you answered true, you are correct. Patients must be enrolled in Rhode Island Health Information Exchange or Current Care or another system approved by the Rhode Island Department of Health to be eligible for mobile integrated health community paramedicine services. True or false? Entities which may provide a patient with a referral for mobile integrated health community paramedicine services may include the patient's primary care provider or emergency department physician only. If you answered false, you are correct. Entities which may provide a patient with a referral for mobile integrated health community paramedicine services may include the patient's primary care provider, emergency department physician, home nursing referrals, Rhode Island Department of Health, or EMS. True or false? According to Rhode Island statewide EMS Protocol 1.05, a mobile integrated health community paramedicine practitioner may opt to provide treatment to a mobile integrated health community paramedicine patient and not transport to a hospital without speaking to the patient's primary care provider. If you answered false, you are correct. The mobile integrated health community paramedicine practitioner may provide treatment at home and not have the patient transported, but only if they are in direct contact with the patient's primary care provider and provided the interventions of the practitioner's scope of practice. Multiple choice. The mobile integrated health community paramedicine practitioner shall call the patient's home or residence prior to arriving. If the patient is not home, the mobile integrated health community paramedicine practitioner shall A. Notify the patient's primary care provider. B. A visit has to be rescheduled within 12 hours unless canceled by the primary care provider. C. Both A and B are correct. D. None of the above are accurate. If you selected C, you are correct. If the MAHCP practitioner calls the patient home or residence prior to arriving and the patient is not home, they shall notify the patient's primary care provider, and a visit has to be rescheduled within 12 hours unless canceled by the patient's primary care provider. Multiple choice. You are a mobile integrated health community paramedicine practitioner and are assessing a patient who becomes diaphoretic with crushing chest pain and shortness of breath. You should A. Activate the 911 system or call for a transporting ambulance for the patient. B. Call the patient's primary care provider and wait for a return phone call. C. Administer one dose of their lisinopril 8-CTZ because their blood pressure is high. D. Do not call a transporting ambulance. Mobile integrated health community paramedicine patients are not supposed to be transported to the emergency department. If you selected A, you are correct. You should activate the 911 system, call for a transporting ambulance for the patient, either via phone or your portable radio. You will also need to contact the patient's primary care provider, and if you cannot get a hold of them, you need to decide whether the patient needs to be transported immediately. If they do, you can attempt to make contact with that physician later or on the way to the hospital. But if assessment, treatment, and transport by EMS is time sensitive, you should not delay those waiting for callback from the patient's primary physician. Thank you for participating in our question and answer session. We hope you did well.